So it turns out that staffing rural EDs and assuring proper onboarding of providers is not a problem unique to the United States. Canadian emergency physician Dr. Michael Austin is a regional paramedic medical director and is investigating innovative ways to care for rural emergency department patients. In some cases, this involves caring for the patient exclusively in their home. Let's join that discussion now. Welcome to another EMCT podcast on the topic of onboarding in emergency medicine. I'd like to introduce Dr. Michael Austin from Canada, our first international guest on this series, where we are talking about elevating the standard, elevating the care of rural emergency patients. And I think we've got an interesting discussion in store for us today. Thank you for joining us, Michael.
Oh, thanks, Stephen, for having me.
Give us a little background on your role in Canada in the health system, a little bit how it works going to the emergency department, and how you care for the entirety of the population, both in the urban setting, those people with emergencies, and those in the rural setting. How do you provide that care?
No, that's great. Yeah, no, excellent. And I think I'll just backtrack a little bit. It's part of my background is I actually worked in New Hampshire for about 6 or 7 years as a paramedic. So spent quite a bit of time in the American system, but also did my medical school training overseas in Australia. So I've had a bit of a good sort of slabbering of different systems and approaches to different things. And one of my sort of interests is really the out of hospital setting. So in the pre-hospital domain as a paramedic or a physician, which I am the medical director for the eastern region of Ontario, which is about 1,500 paramedics, 9 paramedic services. And in in Ontario, we have a ambulance act and a group of sort of standard approaches to care within the province that paramedics sort of fall under. And what's happened over the period of time really from COVID is we've seen a change from the linear approach of 911 response to ambulance response to pick up and to go to hospital to what is the best for the patients that we're engaging in the community in either cities or in either remote areas, but what is the best for that patient? And so we've started to really evaluate that and look for some funding to support paramedics knowledge gap, because this is truly a change in practice to look at new patient models, but also how a physician can support them and mentor them and teach them around this new endeavor around patient safety in that context. And so we've really worked over the last sort of 3 years since the pandemic started to build a cohort of physicians who are dedicated and have some risk tolerance around that to support paramedics in this sort of area and remote communities, and sort of upskill the paramedics to have that capability and knowledge to risk assess and evaluate discharge planning of patients and or alternate destinations other than emergency departments if they're available to support the patient's care. One of the interesting parts of my work in New Hampshire is as a paramedic, I was employed by the hospital. So we actually worked out of the emergency department and responded to calls. And so this is something we're also looking at for really our more remote areas where paramedics may be, lower call volumes, maybe waiting for calls at stations or in different places. And instead of having them wait for calls, have them work during that time, maybe in an emergency department. So we're also looking for funding to bring the paramedic into the ED, have them work with this collaborative team of nurses and physicians, nurse practitioners, PAs, and build this collaborative approach to patient care, but advance their level of skill. And that will, we hope, both help the emergency departments as some are overwhelmed with human resource issues and offload things and support that, but also take those skills out into the community and support the community in any aspects, if it's 911, or we've even started some really robust community paramedic sort of models, which is really taking the patient's care to them and engaging in their chronic illness and other illnesses that come up and trying to provide that care within the home. We recognize, though, that there is a gap, right? There's a gap in knowledge. We've got emergency response paramedics, and some have advanced their level of knowledge and skills in sort of clinical domain. But to bring that all the way up to what we would see as a clinician and evaluating differential diagnoses and determining risk, it's that shift, both in standard education like college, and we're moving to university-based programs, but also to the practice and how we support them in those domains.
Now, in that model, are you thinking that by having those paramedics go to the person's home and help with their cares under physician guidance, it sounds, and closely, is that helping to mitigate the need for going to the emergency department in some settings, or to engage in the healthcare system in another way?
Yeah. So what we're seeing so far, and we're just in the process of doing a larger sort of evaluation of this and adding another 18 paramedic services. But what we've seen in our sort of small pilot of this is we've been able to sort of take the lower sort of acuity patients who call 911, engage the paramedics in identifying that a lower acuity. So we use a CTAS score, and the CTAS of 4 and 5, and we are using the NEWS 2 score just to define the population. And once they've defined the population, then they engage the physician to have a discussion. Is this appropriate for discharging at home or an alternate pathway? And what we're finding is about 95% of that patient population is remaining at home or going to another means, either their family doctor or to a clinic, and not ending up in the emergency department. And we also are following up that population within about 48 hours, and all of them are happy about it, so they're pleased about the process, but also none of them have had any adverse events in the context of that. Of course, things may develop over time in medicine, we know that, right? So patients may present with certain symptoms that aren't perfectly identifiable, and they may present later. But the discharge planning that we're talking to with the paramedics and the patient and the family and engaging in the consent around this, is about that we may have some uncertainty about what's happening to you right now, but right now you seem okay. If X, Y, or Z happens, then of course you need to seek care. And in
Mhm.
any of those cases where any of those things have happened, the patient was aware, they sought care, and the care was provided. So we haven't seen any poor outcomes, and we're seeing a lot of positive responses. Impacting offload delay or emergency department things, I think that's one piece of the puzzle, right? We're going to be able to sort of shave off a little bit of that. But one of the things that I think we hope to do is be able to provide ambulances back into the community to respond to 911 calls. We know that if they're sitting in offload for hours, they can't do that. So can
Mhm.
we, engage this lower acuity patients from long-term care is another example that we've been able to engage with. Can we engage them in treatment within their environment, and then hopefully get that ambulance back off for that cardiac arrest or that sick child down the road, instead of sitting at the hospital?
Yeah. I like the X, Y, or Z. You're giving away your Australasian training there. I've worked in New Zealand a few times in short stints, and and know a little bit of the vernacular
There you go.
and sayings. That's good. So, are there very remote emergency departments where you have difficulty getting physicians to them? And is there a goal, or are there models where these paramedics are used even in those very remote and rural settings?
Yeah, we haven't shifted to that, but I think this concept of having emergency departments sort of staffed with with paramedics and other people while they're waiting for calls, I think could help with that. One of the things that we've done, and this is not just in Ontario, but has been done in other provinces like British Columbia, who sort of led this, is a support model for those more rural and remote areas. So we know that some of these remote areas don't have access to a lot of investigations, and the transport decisions about moving patients around is always a challenge. And sometimes what happens is people are doing locums, or they're less, they don't have as much experience under their belt, and they move to these locations because they're interesting and they're interested in expanding their skills, but they may just need some support in that area. And so in Ontario, it's been about a year, but the peer-to-peer program was sort of established, and that was bringing together a group of emergency physicians who were interested in helping. So they were hired on board, about 30 of them, and they're available 24/7 to these any emergency department, but mostly trying to focus on these more remote areas. And what that's done is it allows that physician to pick up a phone and have a physician on the other end of the phone to say, how can we help? And we've seen a huge uptake in the support and the positive outcomes of that alone. And I think a lot of that has reduced the number of those patients being transferred unnecessarily, helping them support them in their regions, helping make some decisions around that patient care. And I think that's going to only expand. So I think these two models have some synergy. They're kind of similar in their nature, and I think futuristically I could see paramedics supporting paramedics, nurses supporting nurses, physicians supporting physicians, or crossing over across those domains. But a system where you create this support model, whereas if you have a question you can call, and that person has at their fingertips resources to help them. And so we've
Yeah.
seen a lot of really interesting models that have developed because of lots of crises that have occurred, and this is another one of them that has.
Nice. So, what is, on a logistics standpoint, what's the broadband reach in Canada? Is there ability to do tele-emergency medicine in most of these remote locations? Is fiber or high-speed internet available in all these settings?
Yeah, it appears that the majority do. So what's been sort of been around for a little while, and it mostly was established around our traumas and the trauma networks, is the ability to television or video into an emergency department. So each of these remote emergency departments have like a setup where they have a computer with a video screen. And so as a peer-to-peer physician, I can actually log on with that physician through this video interface, and they can move me around the patient. I can zoom in on the patient. I can look at the vital signs. I can do all of those things to support at that patient level care. But that is absolutely available within those domains. Yep.
Nice, nice. And are there physician assistants and nurse practitioners in Canada? Are they playing a role in some of these rural settings as well?
Yeah, so we have some nursing stations that are in a lot of these remote areas, and that's one of the next steps for the peer-to-peer program is to start to engage in supporting them. Nurse practitioners are really starting to, I'll say, engage in a lot of the care, both at nursing home levels. So there's been a big push to engage in some of that frontline sort of reduction in emergency department transfers and patients, see if we can get some clinicians at the nursing homes to help with those, in addition to some of our telemedicine behind our telehealth system, where there's going to be some nurse practitioners. The physician's assistant is a little bit new, but it's developing. And I know we're starting at our academic center training some of those physician assistants in that domain. And I think you and I had talked a little bit about, how do we create some standard approaches to that? And I think that's, all of these sort of endeavors is going to create what is the need, what is the gap, and some of those learning I think will come out of this. And I think those curriculums can be developed a little bit in as we sort of run the cars, but I think there's going to be some opportunities there. One of the unique things in Canada, which we've had an opportunity to learn about, is we have sort of two levels of emergency physicians. We have 5-year trained sort of what we call Royal College emergency physicians that do strictly emergency medicine as their training. And then we have family physicians who do 1 full year of emergency training. And so we have two sort of levels. And we definitely find that the family practice emerge training take a few years to catch up. But the reality is the training and the curriculums that have been designed around this 1-year program has provided them the foundation for them to be able to support in academic centers or even in these rural centers. And I think opening up some of these tele-support systems is only going to help all of those endeavors. So,
Right. And as far as advanced practice providers, we call them in the United States, the PAs and NPs, are they always working in a department with emergency physicians, or do they work solo anywhere?
yeah, some of them work within clinics solo in the context of like family practice clinics. In the emergency department, most of them, because of the models of how billing structures are around, they work side by side with physicians in that model. Yeah.
Okay. What are your volumes in some of your rural EDs? I mean, we have some in the United States that might see, we call them frontier critical access hospitals. They're about 4,500 to 5,000 a year or less. Some are 2,500 volume. Some are 1,000 or less. But they have critical access hospital status. But again, in this frontier setting, where we have a real hard time having physicians at these hospitals, they may have some on staff, but 24/7 is just not tenable for the local physicians and to bring in locum physicians. Do you have emergency departments? I mean, you must have. I mean, Canada is so vast. I mean, and
Oh,
you
yeah.
must have emergency departments with similar issues. How do you get physicians at all of those hospitals?
Yeah, so a lot of them in the sort of the, especially in those rural areas, are staffed by family practice. So what happens is the family practitioners who support the clinics within those communities, and they can be very small as you described, will support those emergency departments or those smaller sort of emergency, clinics, and they may be only 1 to 4 beds, right?
Right.
And they will be, sort of potentially working at their clinic during the day and then covering those at night and then on call in the evenings or overnight, right? So we recognize, and so that's part of some of the work that's being done with this peer-to-peer program is, can we somehow support those to give a reprieve for that group, right? That group is working pretty much 24/7 in these communities, and there's their ability to assist in re-triaging and supporting the nurses that might be in those emergency departments, remotely, and then have that physician see those patients a little bit later on after they've had a bit of sleep, those kinds of things. So there's definitely thoughts around that, but that's really the models in our region, is definitely that family medicine has picked up that ball and recognized they've got to cover those emergencies when they happen in their communities, and we can't have staffed, emergency physicians 24/7 in these smaller volumes, for sure.
Right, right. Well, it sounds like Canada is in a similar evolution of care models and assuring appropriate training as we are in the United States. I think our cart got a little further ahead of the horse than what you have. It seems that you've got it throttled if you've got emergency physicians there. Politically, we had independent practice occur in emergency departments without proper conditions of participation in place, with surrounding the issue of training, required
Mm.
minimum standard of training. And so we're still working through that process, but we've got advocacy organizations. I mean, of course, ACEP, our American College of Emergency Physicians, but working with the Society of Emergency Medicine PAs and the American Academy of Emergency Nurse Practitioners. They're all putting together criteria for minimum standard to be able to work in those facilities, so that we don't have very inexperienced providers there and putting patients at risk. So we've got a lot of work to do yet, though, to get that standard in place. But that's what this onboarding series is about, and it's good to hear that other countries struggle with the same issue as well.
Yeah. Geography, I think, is always a challenge, right?
Yeah,
I think what we did learn from the pandemic, if anything, is that the ability to interface in some sort of, if video interface like this,
yeah.
can really be supported by sort of that platform. And I think historically we sort of didn't take it on as much as we are now. And I think that's opened up some of those opportunities, but also recognize some of the gaps that you're describing, right? Are we creating a standard approach to every person who walks into any emergency department in our country? And the answer, of course, is no, we can't. How can we bring that bar up? And I think one way is trying to facilitate the highest level of care at that facility, or can we bridge it with supported models that can provide that service if needed by just a phone call or a video interface? And I think there's been some good work around that. And I think that may be something that might work. It's not going to be the answer, but it may be very helpful.
Right, right. Yeah, in my rural work in New Zealand, I worked in Topo in the center of the country, and I was thankful to have a nurse midwife that would take care of the OB and then would have the patient transported by helicopter immediately if it was going to be a difficult delivery, and screening those, and for those simple deliveries they did right at pretty small rural hospital. That was nice, but in the emergency department they had experienced physicians even in these smaller hospitals, and a real high bar to be able to work there, and you needed that because you didn't have the resources. There was no surgeon. In fact, the first 2 times that I went there in 2016 and 2017, I didn't have a CT scanner. Uh, so, and now this last time I was there about a year ago or so, we had it available Monday through Friday, at least from like 9 to 3 in the afternoon. So you could hold people. So yeah, it's a different model, but you really have to, have a firm foundation in emergency medicine to be able to practice in the rural setting and perform procedures that, in the larger institution, you might just turn over to interventional
Absolutely.
radiology or to the trauma surgeon or whoever. No, you need to step up and do those procedures that can be life-saving, or at least making patients more comfortable.
Absolutely. No, I totally agree with you. And I think one of the things that I think we're working on with our curriculum around our Royal College trained physicians in emergency medicine is to get them that experience to go out to more remote areas and see that it's not just about determining that the patient has X and we can just refer them to the specialist. It's about managing that patient until the helicopter or the transport unit comes, and you may even have to go with them in that transfer. And that's a totally different environment, and your skill set needs to be totally different. And so I think you're absolutely right. We've made some really big strides in linking our academic centers to a lot of our remote and sort of communities. So we have that access, that sort of head of the octopus and sort of tentacles that go out, so we can send our trainees out to work. So that helps them, right? So it adds some level of staffing and some expertise, and they can train and educate and learn. And we're able to sort of communicate and engage and provide them resources, right? Even online resources for standard approaches to people with DKA and things like that that you may not see often enough, but at least it creates a standard approach to care.
Yeah. And there aren't enough emergency medicine trained and boarded physicians to go to all these facilities, but it's amazing you can live urban and make a tremendous impact in the rural setting by overseeing several emergency departments really simultaneously as you take call, just because those volumes are lower, and depending on the experience of the provider or the physician in your case that's there, they can call when needing support, and conceivably you could cover an entire host of emergency departments remotely, and
Yep.
provide that support and still be able to indulge your interests in working at a high volume facility and living in the city, but again have that tremendous impact rurally.
Yep. No, absolutely. Yep. And trying to just create that standard. So yeah.
Yeah. Well, cool. Yeah, so we're still working on getting minimum educational standard in the US, and working with our various colleagues in advocacy organizations. Again, ACEP being at the lead of this, but also working with SEMPA and AAEMP, and working with our family practice and other specialists. For those that didn't do residency in emergency medicine, there are programs, 1-year fellowships as well, available, and clinical experience tracks for physicians to be able to get boarded through the American Board of Physician Specialties, as opposed to the American Board of Medical Specialties, which is the traditional board that many of us went through. So yeah, a lot of these efforts in place to raise that bar, improve the education of rural providers, and yeah, we're working to put those standards in place here. But it's good to hear of the similar struggles there as well in Canada,
Absolutely.
and how
Yep.
you care for this difficult population that's remote, and and how you get the physicians to those emergency departments and staff clinics and emergency department at the same time. It's long hours for those physicians in those communities.
Absolutely.
Yeah.
Absolutely. Yep. Yep. No, for sure. I think as we build any of these things, we just keep the patient in the center of the whole discussion. I think we'll win in every turn. But I think you're absolutely right. It's exciting times, to be honest, right? It's I think it's identified some of those holes, but I think we're working to fill them. So it's great. Yeah.
Yeah. Well, cool. Well, I appreciate hearing about the work you're doing there, and your role in helping to advocate for those rural patients and all. So appreciate you coming on, Michael. Thank you.
No worries. No, thanks for having me.